Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 308 of our pharmacotherapy series, which majors in cardiac arrhythmias. The first question relates to patient JKL in part 307 of this pharmacotherapy series. Warfarin treatment is begun and JKL's prothrombin time is to be maintained at an international normalized ratio (INR) of 2 to 3. JKL is scheduled for a transesophageal echocardiogram, abbreviated as TEE, to determine whether cardioversion can be performed during this admission. How does a transesophageal echocardiogram help to determine whether cardioversion can be performed, and why is warfarin therapy being used? When the onset of atrial fibrillation is less than 48 hours, the likelihood of atrial clot formation is low. However, if patients are at a high risk for stroke, they should receive an anticoagulant, such as an unfractionated heparin, a low molecular weight heparin, a factor Xa, or a direct thrombin inhibitor, as soon as possible surrounding the cardioversion, followed by long-term anticoagulation. When the duration of atrial fibrillation is greater than 48 hours, or if duration is unknown, then an oral anticoagulant agent, such as warfarin, dabigatran, or a factor Xa inhibitor, should be given for 3 weeks before cardioversion at doses providing an INR between 2 and 3 if using warfarin. Studies in patients with atrial fibrillation showed that those who were anticoagulated with warfarin before cardioversion had a lower incidence, that is 0.8%, of emboli than those who were not anticoagulated, that is 5.3%. Alternatively, a transesophageal echocardiogram can be used to determine whether atrial clots have formed. Atrial clots form most often in small side pouches on the atria called atrial appendages. Because the frequency of right atrial appendage thrombosis is half that of left atrial appendage thrombosis in atrial fibrillation patients, the risk of stroke is enhanced much more than the risk of pulmonary embolism. If no clot is observed on transesophageal echocardiogram, then there is low risk for stroke with cardioversion of atrial fibrillation. However, if an atrial clot is evident on transesophageal echocardiogram, JKL would need to be adequately anticoagulated for 3 weeks before cardioversion to prevent embolization of the clot and stroke. If cardioversion is successful, patients should remain on an oral anticoagulant agent for at least 4 weeks after cardioversion because normal atrial contraction may not return for up to 3 weeks, and patients may be at risk of late embolization. The decision to provide long-term oral anticoagulation is dependent on the patient's underlying stroke and bleeding risk. This will be discussed further below. The next question reads, JKL was found to be free of atrial clots. Chemical cardioversion with ibutylate is planned for tomorrow. If JKL fails to convert with ibutylate, he will be electrically cardioverted later in the day. How does ibutylate therapy compare with the other therapeutic choices for chemical cardioversion? The most effective method of cardioversion is by direct current, abbreviated as DC cardioversion. However, the use of direct current cardioversion may be undesirable if the patient is a poor candidate for conscious sedation or if the patient is not willing to undergo direct current cardioversion. In these situations, pharmacologic cardioversion may be attempted. Many Class 1 and 3 antiarrhythmic agents have been evaluated for efficacy in placebo-controlled trials for conversion of atrial fibrillation or atrial flutter to normal sinus rhythm. The available agents with the most positive data for chemical conversion include IV ibutylide, oral propafenone, oral flecainide, oral and IV amiodarone, and oral dofetilide. This section will focus on ibutylide, propafenone, and flecainide. IV ibutylide, a Class 3 antiarrhythmic agent with potassium channel blocking and slow sodium channel enhancing effects, was the first agent that the U.S. Food and Drug Administration (FDA) approved for the termination of recent-onset atrial fibrillation and atrial flutter. Ibutylide is administered as a 1 mg infusion for 10 minutes, followed by another 1 mg infusion for 10 minutes if conversion has not occurred by 10 minutes after the infusion. The conversion rate for recent-onset atrial fibrillation is 35% to 50%, the conversion rate is 65% to 80% in atrial flutter. In a retrospective study of hospital inpatients with either atrial fibrillation or atrial flutter, 50% of patients converted initially, 41% conversion atrial fibrillation, 65% atrial flutter, but only 33% of patients left the hospital in sinus rhythm. If the duration of atrial fibrillation or atrial flutter before cardioversion was fewer than 15 days, significantly more patients remained in sinus rhythm at discharge compared with patients who had atrial fibrillation or atrial flutter for more than 15 days before cardioversion. As is the case with most Class 3 antiarrhythmic agents, the main adverse effect is torsade de poor, which occurred in approximately 4% of patients. Ibutylide should be avoided in patients with hyperkalemia, hypomagnesemia, QT prolongation, and a low ejection fraction that is less than 30%. Aside from the risk of torsade de poor, therapy is well tolerated. Propafenone is a Class 1C agent with beta-blocking properties. When given in doses of 450 to 750 mg orally, 600 mg was the most common dose. The initial conversion rate in patients with atrial fibrillation ranged from 41% to 57%. In contrast to ibutylide, no patients experienced ventricular arrhythmias, including torsade de poor, but a risk of hypotension, bradycardia, and QRS prolongation was noted. Oral flecainide is another Class 1C antiarrhythmic agent. In one study, 300 mg oral flecainide converted 68% of patients to sinus rhythm within 3 hours and 91% of patients by 8 hours. The efficacy in atrial flutter has yet to be established. Sinus node dysfunction, prolongation of intraventricular conduction, dizziness, weakness, and gastrointestinal (GI) disturbances have been reported. A beta blocker or non-dihydropyridine calcium channel antagonist should be administered equal to or more than 30 minutes before administering the Vaughan-Williams Class 1C agent to prevent a rapid ventricular response due to 1:1 AV conduction during atrial flutter. JKL is not a candidate for these agents due to his structural heart disease. The next question reads, JKL received 2 doses of IV ibutylide. After the second dose, he converted to normal sinus rhythm for only 5 minutes, then returned to atrial fibrillation. JKL is scheduled for electrical cardioversion in 6 hours. What is electrical cardioversion? How efficacious and safe is it? Direct current cardioversion quickly and effectively restores 85% to 90% of patients with atrial fibrillation to normal sinus rhythm. If direct current conversion alone is ineffective, it can be repeated in combination with antiarrhythmic drugs. In one study, the success rate of electrical cardioversion was significantly higher in atrial fibrillation patients. Duration of atrial fibrillation averaged 119 days with ibutylide pretreatment 1 mg compared with those without pretreatment 100% versus 72% with a p-value equal to 0.001. This is because ibutylide pretreatment lowered the energy requirement for atrial defibrillation by 27%, with a p-value equal to 0.001. TDP occurred in 3% of patients receiving ibutylide, all of whom had an ejection fraction less than 20%. Flecainide, propafenone, amiodarone, and dofetilide could also be considered for enhancing direct current cardioversion. Direct current cardioversion is clearly indicated for patients who are hemodynamically unstable. A reason one may wish to avoid direct current conversion is because anesthesia, short-acting benzodiazepine, barbiturate, or propofol, is required for the procedure. The next question reads, JKL is discharged after successful direct current conversion. However, when he returns for a follow-up visit 2 weeks later, he is found to be in atrial fibrillation again. He again reports frequent palpitations. His physician would like to initiate an antiarrhythmic drug to maintain normal sinus rhythm. Which agent or agents would be the best option for this patient? To choose the best antiarrhythmic agent for JKL, the efficacy and adverse effect profiles for each agent should be reviewed. Class 1A, 1C and 3 antiarrhythmic drugs prevent the recurrence of atrial fibrillation. Flecainide, sotalol, dofetilide, and dronedarone are approved by the FDA for maintenance of sinus rhythm. Propafenone and amiodarone are commonly used as well. Let's discuss about flecainide and propafenone. The Class 1C agents flecainide and propafenone are effective in suppressing atrial fibrillation. The efficacy rate may be as high as 61% to 92% for flecainide. Flecainide and possibly other Class 1C agents are proarrhythmic, especially in patients with structural heart disease, and they should be avoided in such patients. Propafenone, a Class 1C agent with beta-blocking properties, is as efficacious as flecainide and is relatively safe in patients without ischemic heart disease and an ejection fraction greater than 35%. It may be preferred in patients who require additional AV blockade to control ventricular response. In a direct comparison with flecainide 200 to 300 mg per day, propafenone 450 to 900 mg per day was equally safe and effective. Over the course of 12 months, a similar percentage of patients, approximately 12% in each group, did not have adequate control of their arrhythmia. Adverse events were comparable and occurred in 10.3% of patients on flecainide and 7.7% of patients on propafenone. Of all the adverse events noted, only one patient who was receiving propafenone developed a ventricular arrhythmia. Another one-year comparative study of propafenone versus flecainide demonstrated similar efficacy, but this study showed a trend toward better tolerability in the flecainide group. The next question reads, JKL is to begin dofetilide today. He is admitted to the hospital for dofetilide initiation. Why would JKL need to be admitted for dofetilide initiation? Is it necessary to initiate all antiarrhythmic medications in the hospital? Class 3 agents, such as sotalol, dofetilide, amiodarone, dronedarone, prolong refractoriness in the atria, ventricles, AV node, and accessory pathway tissue and can prevent recurrence of atrial fibrillation. All of these agents act by blocking potassium channels, however, sotalol also has additional beta-blocking properties. Both amiodarone and dronedarone block sodium channels and calcium channels, and have antiadrenergic effects in addition to potassium channel blocking properties. Let's take a closer look at sotalol, amiodarone, dofetilide, and dronedarone. The efficacy of sotalol in delaying the recurrence of atrial fibrillation was evaluated in a double-blind, placebo-controlled, multi-center, randomized trial that enrolled 253 patients with atrial fibrillation or atrial flutter. The median times to recurrence were 27, 106, 229, and 175 days with placebo. Sotalol 160 mg per day, divided in 2 doses, sotalol 240 mg per day, divided in 2 doses, and sotalol 320 mg per day, divided in 2 doses, respectively. Sotalol is contraindicated in patients with a creatinine clearance of less than 40 ml per minute because of the fact that the drug is largely renally cleared and can cause torsade de poor in high concentrations. In a comparative study versus propafenone, sotalol was similarly effective in producing at least a 75% reduction in atrial fibrillation recurrence, 79% of patients on propafenone versus 76% on sotalol. Bradycardia, dizziness, and GI disturbances were the most common intolerable side effects. Sotalol should not be used in patients with systolic heart failure owing to the negative inotropic effects of the drug. It may be useful as a first-line agent in patients with atrial fibrillation and concomitant underlying coronary artery disease or in patients with no cardiovascular disease. Amiodarone is more effective at maintaining sinus rhythm than sotalol and propafenone. The Canadian Trial of Atrial Fibrillation, abbreviated as CTAF, compared the ability of low-dose amiodarone 200 mg per day versus propafenone 450 to 600 mg per day and sotalol 160 to 320 mg per day to prevent recurrence of atrial fibrillation. After a mean follow-up of 16 months, 35% of the amiodarone-treated patients had a recurrence of atrial fibrillation versus 63% in the combined group with sotalol and propafenone with a p-value equal to 0.001. In view of its unusual pharmacokinetics and potential serious adverse effects, amiodarone is only recommended as a first-line choice for patients with heart failure, for which it has specific safety data, or for patients with significant left ventricular hypertrophy. Amiodarone could also be used when other agents such as sotalol, propafenone, or dofetilide have failed. Dofetilide has been shown to be an effective pharmacologic agent for conversion to, and maintenance of, normal sinus rhythm. 2 clinical trials, that is the EMERALD, an abbreviation of the European and Australian Multi-Centre Evaluative Research on Atrial Fibrillation Dofetilide Trial, and SAPPHIRE-D, an abbreviation of the Symptomatic Atrial Fibrillation Investigation and Randomized Evaluation of Dofetilide Trial, have shown conversion rates of 30% in patients with atrial fibrillation or atrial flutter receiving higher doses of dofetilide. Patients failing chemical conversion received electrical conversion. If this conversion succeeded, they were continued on dofetilide for 1 year. At 1 year, 60% of those converted were still in sinus rhythm with the 500 microgram dose. Also, dofetilide appears to exert neutral effects on mortality rates in heart failure and post-myocardial infarction patients. Dofetilide dose is based on the patient's creatinine clearance. The doses are 500, 250, and 125 micrograms twice daily with creatinine clearance greater than 60, 40 to 60, and 20 to 39 milliliters per minute, respectively. Drug interactions pose a significant problem with dofetilide. Cimetidine, ketoconazole, prochlorperazine, migestrol, and trimethoprim, including in combination with sulfamethoxazole, inhibit active tubular secretion of dofetilide and can elevate dofetilide plasma concentrations. Because the incidence of torsade de Poor is directly related to dofetilide plasma concentrations, concomitant use with these agents is contraindicated. Concomitant administration of dofetilide with verapamil or hydrochlorothiazide increases the incidence of torsade de Poor by an unclear mechanism and is contraindicated as well. Concurrent use of agents that can prolong the QTc interval is not recommended with dofetilide. Dofetilide also undergoes metabolism by the cytochrome P450CYP3A4 isoenzyme to a minor extent. Therefore, inhibitors of this isoenzyme, e.g., azole antifungal agents, protease inhibitors, serotonin reuptake inhibitors, amiodarone, diltiazem, nefazodone, zafirlukast, should be co-administered with caution with dofetilide. Other agents that can potentially increase dofetilide levels, through inhibition of tubular secretion, include metformin, triamterene, and amiloride. Hence, these agents should be cautiously co-administered with dofetilide. Dofetilide is considered a first-line agent for patients with heart failure or coronary artery disease, as the impact on mortality in this patient population is neutral. Dofetilide can also be considered as a first-line agent for patients without cardiovascular disease, but should be avoided in patients with severe left ventricular hypertrophy. Dronedarone is structurally and pharmacologically similar to amiodarone, however, it lacks iodine, and it has a much smaller volume of distribution than amiodarone. The lack of iodine may make dronedarone less likely to cause thyroid-related or other adverse effects. Dronedarone has been shown to have modest efficacy in maintaining sinus rhythm when compared with placebo. The rate of recurrence of atrial fibrillation at 1 year is approximately 40%, and the number of days to recurrence is nearly doubled with dronedarone. The major clinical trial evaluating dronedarone was the Athena study. The primary endpoint of Athena was a composite of death or cardiovascular hospitalization, and patients received either dronedarone 400 mg twice daily or placebo for at least 1 year. The primary composite endpoint was significantly reduced from 39.4% with placebo to 31.9% with dronedarone. This reduction in the composite was completely attributable to the reduction in cardiovascular hospitalizations, most of which were related to atrial fibrillation recurrence. GI events were the most common type of adverse effect with dronedarone in this study. It should be noted that patients with recent decompensated heart failure or New York Heart Association Class 4 heart failure were excluded from this trial. The exclusion of patients with severe or unstable heart failure was related to negative findings that led to the early discontinuation of the Andromeda study. Andromeda was designed as a safety study, to evaluate the impact of dronedarone on mortality in patients with heart failure. Patients admitted with New York Heart Association Class 3 or 4 systolic heart failure were included in this study. The study was stopped early because of an approximate doubling in the risk of death with dronedarone as compared with placebo. Therefore, dronedarone is contraindicated in a patient with severe or recently decompensated heart failure. Based on the findings of the PALACE study, dronedarone should be avoided in patients with permanent atrial fibrillation as well. This study found that the rate of stroke, heart failure, and cardiovascular death was increased when dronedarone was used in this patient population. Dronedarone has also been compared directly with amiodarone. In this study, dronedarone was less effective than amiodarone, but was less likely than amiodarone to cause thyroid, neurologic, skin, or ocular adverse effects. GI adverse effects were more common with dronedarone. Dronedarone is appropriate as a first-line agent for patients with atrial fibrillation and concomitant coronary artery disease, and possibly left ventricular hypertrophy, or in patients with no cardiovascular disease. Dronedarone should not be used in a patient with severe heart failure symptoms or a recent hospitalization for heart failure, but may be used with mild, well-controlled heart failure. In view of JKL's heart failure, sotalol, propafenone, and flecainide would not be indicated. Although dronedarone may be better tolerated than amiodarone, it would be contraindicated because JKL was recently admitted with decompensated heart failure. Therefore, the only available options for JKL would be either dofetilide or amiodarone, both of which have been proven safe in patients with heart failure. Selection between dofetilide and amiodarone could be based on renal function, the presence of any major drug interactions, or the desire to avoid adverse effects with amiodarone. Dofetilide was approved with the requirement for in-hospital initiation because of the relatively high risk of torsades de poids in clinical trials. ECG monitoring is required for patients being initiated on dofetilide for a minimum of 3 days in a properly equipped facility. The initial regimen is determined by the patient's estimated creatinine clearance. The QTC interval must be measured, using a 12-lead ECG, 2 to 3 hours after the first dose and each subsequent dose while the patient is hospitalized. If the QTC interval increases by greater than 15% or if it surpasses 500 milliseconds, that is above 550 milliseconds in patients with ventricular conduction abnormalities, after the first dose, the dofetilide regimen should be reduced by 50%. If the QTC interval exceeds the above parameters any time after the second subsequent dose, dofetilide should be discontinued. Sotalol may also be arrhythmogenic in high doses, and the risk of inducing torsades de poids has prompted its manufacturer to mandate a minimum of 3 days of ECG monitoring in a properly equipped facility during therapy initiation as well. Further, during initiation and titration, QTC intervals should be monitored 2 to 4 hours after each dose. In fact, most antiarrhythmic agents for atrial fibrillation should probably be initiated in the inpatient setting, with the exception of amiodarone owing to the low risk of proarrhythmia with this drug. The next question reads, JKL is discharged from the hospital on dofetilide 500 micrograms twice daily, which is appropriate given his creatinine clearance of 92 milliliters per minute. He has been doing fine for 2 weeks after discharge. Should JKL remain on warfarin therapy? Could any other antithrombotic options be considered? Patients with nonvalvular and valvular atrial fibrillation have a 5 and 17-fold increased risk for stroke compared with patients without atrial fibrillation, respectively. Stroke can lead to death or significant neurologic disability in up to 71% of patients, with an annual recurrence rate as high as 10%. In 3 large randomized trials, patients with nonvalvular atrial fibrillation benefited from antithrombotic therapy. In the stroke prevention in atrial fibrillation, abbreviated as the SPARF study, both aspirin 325 mg per day and warfarin, titrated to an INR of 2 to 4.5, reduced the risk of stroke significantly with an acceptable level of hemorrhagic complications. The results of SPARF-2, a direct comparison of warfarin and aspirin, indicated that warfarin was more effective than aspirin in preventing stroke. These results were verified by the Copenhagen AFASA case study, which found warfarin to be significantly better than aspirin and placebo at preventing cerebral emboli and overall vascular deaths, cerebral and cardiovascular. An oral direct thrombin antagonist, dabigatran, and oral factor Xa antagonists, such as rivaroxaban, apixaban, or edoxaban, are now available. These newer anticoagulant agents have been shown to have similar or better efficacy and safety compared to warfarin. Dabigatran is approved by the FDA to reduce the risk of stroke and systemic embolism in patients with nonvalvular atrial fibrillation. In the RELY trial, dabigatran 110 mg twice daily and 150 mg twice daily was compared with warfarin in patients with a CHADS-2 score of 1 or more, average CHADS-2 score of 2.1. The CHADS-2 score is a tool used to estimate stroke risk. In this study, the lower dose of dabigatran was non-inferior to warfarin for stroke prevention but was associated with less bleeding. High-dose dabigatran was superior to warfarin for stroke prevention but comparable in bleeding. The most common non-bleeding adverse event in this study was GI upset. It should also be noted that dabigatran capsules should not be chewed or opened. The 3 oral factor Xa inhibitors that are currently approved for prevention of stroke and systemic embolus in patients with atrial fibrillation include rivaroxaban, apixaban, and edoxaban. Each of these agents have been compared directly to warfarin using fairly similar study designs. Rivaroxaban and edoxaban were found to be non-inferior to warfarin in stroke or systemic embolus prevention, while apixaban was found to be superior to warfarin in efficacy. Major bleeding occurred less frequently with edoxaban and apixaban and at a similar rate with rivaroxaban, compared to warfarin. Although efficacy and safety of all of the new agents differed when compared with warfarin, there are no direct comparisons between any of the newer antithrombotic options. As such, no firm conclusions can be drawn regarding the optimal agent to choose. However, in a patient who is perceived to have a high bleeding risk, it is reasonable to select apixaban or edoxaban, given the bleeding risk advantage of these agents relative to warfarin. Some differences between the newer agents could be considered when selecting an anticoagulant regimen for a patient. For example, each agent has different recommendations for use with kidney dysfunction. None of the newer oral agents should be used in patients with a creatinine clearance less than 15 ml per minute. The renal doses of rivaroxaban 15 mg per day with creatinine clearance of 15 to 49 ml per minute and edoxaban 30 mg per day with creatinine clearance of 15 to 50 ml per minute were evaluated in the ROCKET AF and ENGAGE AF TIMI 48 studies, whereas the renal dose adjustment recommended for dabigatran 75 mg twice daily dose for those with a creatinine clearance of 15 to 30 ml per minute was based on extrapolated pharmacokinetic data. Apixaban does not require dosage adjustment based on a creatinine clearance, but adjustment should occur if the patient has 2 or more high-risk characteristics, body weight 1.5 or age over 80 years. Interestingly, edoxaban is less effective and should not be used when creatinine clearance is greater than 95 ml per minute. Therefore, edoxaban, apixaban, or rivaroxaban may be a more evidence-based option than dabigatran for a patient with poor kidney function, and edoxaban would be an inappropriate choice for the patient with very good kidney function. The drug interaction profiles of the oral direct thrombin inhibitor or oral factor Xa inhibitors are favorable compared to that of warfarin. All of the newer anticoagulant options interact with rifampin. Rivaroxaban and apixaban also interact with other strong inhibitors and inducers of both the P-glycoprotein and CYP3A4 systems. Dabigatran interacts with inhibitors of P-glycoprotein, e.g. ketoconazole, or dronedarone. However, no change in therapy is required unless the interacting drugs are used in a patient who also has a creatinine clearance less than 50 ml per minute. At this time, no notable interactions have been identified with edoxaban, other than the interaction with rifampin. Although the number of interactions with the newer anticoagulants is fewer than with warfarin, it will still be important to evaluate for the presence of interactions at therapy initiation and when the drug therapy regimen is changed. An advantage of dabigatran and the oral factor Xa antagonists is that these agents do not require frequent monitoring and dosage adjustment in order to assure an appropriate level of anticoagulation. A potential disadvantage is that it is often not possible to monitor the extent of anticoagulation in the setting of bleeding or when an urgent procedure or surgery is needed. In addition, strategies for reversal of these agents are not well defined, in contrast to the reversal approach with warfarin. Best available evidence suggests that concentrated blood factor products, 4-factor prothrombin complex concentrates and FEIBA may be options for reversing the effects of these agents. However, specific reversal agents are likely to be commercially available in the near future. Hemodialysis can also be used to remove dabigatran, in the setting of life-threatening bleeding. Generally, patients with a CHA2DS2-VASC score of 2 or greater should receive anticoagulant therapy for stroke prophylaxis. Warfarin, with an INR target 2 to 3, dabigatran, rivaroxaban, apixaban are all recommended as antithrombotic agents for stroke prophylaxis. Edoxaban was not approved at the time of publication of the 2014 guidelines for atrial fibrillation and is not currently included, but has FDA approval. No therapy, an antithrombotic agent, or aspirin alone could be used in patients with a CHA2DS2-VASC score of 1 and stroke prophylaxis is not required if a patient's CHA2DS2-VASC score is 0. If a patient's INR is difficult to control on warfarin, a direct thrombin inhibitor or oral 10A antagonist could be used. It should be noted that patients with atrial fibrillation and valvular disease should only be treated with warfarin for stroke prophylaxis, as data with valvular atrial fibrillation are either unfavorable or unavailable with the newer agents in this patient population. Even though JKL is in normal sinus rhythm at this time, in the AFFIRM trial, only 73% and 63% of patients randomized to rhythm control remained in sinus rhythm at 3 and 5 years, respectively. As such, the use of an antiarrhythmic drug does not eliminate the risk of stroke, and in fact, patients may return to atrial fibrillation and not be aware they are no longer in normal sinus rhythm. JKL has a CHA2DS2-VASC score of 4 and does not appear to have any factors that would suggest a high bleeding risk. He has not had recent history of GI bleeding, etc. Therefore, he should continue to receive anticoagulation for stroke prophylaxis. Although JKL is currently taking warfarin, there would be no reason he could not receive any of the other available anticoagulants. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 309.